All right, I'm just gonna give it a minute so people start coming in, see like they are joining and connecting. So I'll just give it a couple of seconds or a minute. Are you still here in the Cape Town vicinity?
Yes. Is everyone else based in Cape Town except for Alwyn, or is there other locations as well?
Yeah, I need to think. I think it's mostly him. Morning, Doctor. You're gonna go? Just give me one more second for those to join. Yes. Okay. They seem to be still connecting or something. Pardon me. But okay, so I think we can start in just a second. See everybody here, otherwise. Another sister here. Okay, I think we can get the ball rolling. There's still people coming in, but we can at least get it going. I think we might run out of time here as well. So for those that is already on, all the sisters, thank you guys for joining this webinar and such. Just a quick one, as the presentation carries on, and you have a question or anything of that sort, just tap on your screen once. You can look at the bottom. You'll find there's a couple of options there where you can either raise your hand, but that's going to be sort of afterwards, after the presentation, for any questions regarding that. There is also a chat function at the bottom of this webinar where you can start typing your questions and such, and any comments as we go along. So you're welcome to use that feature at any time during our webinar. And we'll have a Q&A afterwards as well, where you can then either raise your hand if you wish to chat, or if you wish to talk rather. But we'll also have that chat functionality where you can type your questions. Let's just do this. All right, so for those again that hasn't met Dr. Cassim, she's one of our panelist doctors here in Udok. So she will have an interesting use case for us again to present and elaborate on. So yeah, without further ado, Dr. Cassim, you can take the floor.
Good morning. I hope that everyone's well today. I'm just going to try share my screen. I think you need to make me a host as well. Otherwise it's not going to work.
No, it's just a screen functionality for some other reason. It keeps doing this. Let's see. Okay. Yeah, it should work now.
There we go.
Okay, super.
Okay, so like we previously mentioned, today's topic is hypertension, something that comes through quite frequently via the Udok platform. It's also known as the silent killer because it often is the risk factor that leads to other cardiovascular problems, such as the strokes, the myocardial infarctions, and then a whole host of other target organ damage that it can cause to the kidneys, to the eyes, to all of the other organs in the body as well. I just wanted to go through some of the basics just to refresh everyone, and then we can have some questions at the end as well. So first and foremost, I want to go through the process of actually taking an accurate blood pressure. I know when we see something quite frequently, we all tend to fall into bad habits, and we kind of do it in our own way after a while, whereby we've kind of forgotten that if we are not accurate in determining our figures, we can actually throw off the diagnosis and the management thereafter. So it's always good to just refresh what actually should be happening when you take a blood pressure. So the patient should be seated with their back firmly against the chair, feet touching the floor, not sitting with their feet off the ground or their legs crossed or slouching or anything like that. Let them sit down. So don't do the blood pressure as they walk in through the door. Let them sit down for 3 to 5 minutes, be in a relaxed position, be calm, not have just been running in from work or lunch or whatever it was that they were doing prior to the consult. And then let their arms rest at the level of the heart for about 3 to 5 minutes. Ask them about caffeine and smoking use prior. Ideally, they should have avoided caffeine and smoking 30 minutes prior to taking their blood pressure. Ask them if they have gone to the bathroom. Ideally, they also should empty their bladder before you take it. Then in those 3 to 5 minutes, try to create a calm environment and avoid them talking as much as possible. I know that's quite difficult because it is a consultation, but it really does affect the pressure readings taken. Then with regards to the cuff, you want to put it over bare skin or light clothing. Please don't put it over jackets, or don't roll up the clothing and then put the cuff over as well. Then make sure that you also choose the correct cuff size. So if they have a mean upper arm circumference of more than 33 centimeters, please use a larger cuff. And then for children also, please make sure that you adjust and use the smaller cuffs as well. And then you would want to ideally take 2 readings that are 2 minutes apart so that you can kind of get an average and see from there. Then what is a normal reading? So as we all know, blood pressure usually brings back 2 numbers that's known as the systolic blood pressure and the diastolic blood pressure. So systolic blood pressure is the first number, and that is actually an indication of how much pressure your blood is exerting against the artery walls when your heart pumps. So that is the first number. The second number is the diastolic blood pressure, and that indicates how much pressure your blood exerts against the artery walls when your heart is at rest and filling in between the beats. So those are the 2 numbers that basically come back after you've taken a blood pressure reading. The normal is less than or equal to 120 over 80. And then there are various other categories. So this is the new category stratification that I found online. And I think this is the American Heart Association one, whereby they say that if you are between the ranges of a systolic of 120 to 129 and a diastolic that's still less than 80, we're going to term you as elevated blood pressure. In this category, it's not necessarily that you are going to receive medical treatment in the form of tablets or anything. You're just going to basically get diet and lifestyle counseling, and you will be monitored every 5 years, they recommend. Then in category 1, which is what they're now calling high blood pressure stage 1, they're saying that's a systolic of between 130 to 139, or a diastolic between 80 to 89. So before we had the blood pressure cutoff of 140 over 90 to make you hypertensive, but in this categorization, I see they've added the 2 levels beforehand. I think it's just that we can identify early who those are at risk of developing hypertension and follow them up more regularly. So they added in the elevated and the stage 1 category as well. So this stage 1 category as well, not necessarily goes on to treatment, but they do get diet, lifestyle changing advice. And then they also follow up more regularly. So they recommended that they follow up yearly as well. Then stage 2, which is the 140 systolic or higher, or diastolic of 90 or higher, which is classically what in the old terminology we classified as hypertensive. that is now classified as hypertension stage 2. And these are your patients that get diet, lifestyle, and they also start medication as well. And then previously, we used to talk about hypertensive urgencies and emergencies, and it got a bit confusing where people were always wondering what is an urgency and an emergency. And I think the difference between the two was just that an emergency had target organ damage, which required immediate medical assistance. But now they've termed it as hypertensive crisis. So that is a systolic of more than 180 and a diastolic of more than 120. Some guidelines say the diastolic more than 130, so it does vary. And those are the ones that you give urgent medical attention to. So let's go through the categories again, just a little bit more in detail. So the normotensive or the mildly elevated, and that is less than 140/90, that would be in the categorization that I spoke of before. That would be the, just go back, sorry, I think it's just gone way too far now. That would be this one over here, the normal, the elevated, and the high blood pressure stage 1. So in those categories, you are assessing your CVD risk as well. So ask the patient about their cholesterol levels, their sugar levels, when last did they do a basic health screening, check their BMI and their weight. Are they obese? Are they at risk for obesity? Are they mildly overweight? Are they smoking at the moment? What is their family history like? Or have they also had any previous cerebrovascular incidents, like have they had strokes? Have they had myocardial infarcts? Are they known with blood clots, etc., etc.? And then we're counseling on general lifestyle choices. So regarding their risk factors, you would then counsel appropriately and then follow up as needed. I went through the follow-ups that were suggested for those categories. Then the hypertensive stage 2, or the previously what we just called hypertensive category, that's more than 140/90 with no warning signs. Please do not ever diagnose a patient as a proper hypertensive on a single consult alone or a single reading alone. We need to check on 2 further occasions, at least 2 days apart. So usually if someone presents to the clinic, sister, and their blood pressure readings are very high and it's the first time, I will often counsel the patient and then tell them to please follow up the next week or within 2 weeks' time whenever they get a chance, or sometimes even if they are willing and able to come in for multiple readings throughout the 2-week period, so we can actually track and see what those blood pressures are doing throughout the day, and if it was just a once or false reading, or if it's actually a true hypertensive diagnosis. If your patient is under the age of 30, then you must think that they do actually have an underlying cause for this high blood pressure, and they actually need to be worked up further for possible renal artery stenosis or various other medical conditions that is causing this high blood pressure. If a true diagnosis is then made after all of these checks, then what you want to do is start counseling on diet and then start discussing the use of antihypertensives. It's very good. I know we don't often do it in the clinic setting, but it's actually very good to do a urine dipstick just to check for protein urea as well. And then if the patient can and is willing, I will often attach a lab form and ask them if they can get 4 more bloods just to check the GFR and the kidney function status as well. Then we also want to counsel them regarding risk factor stratification. So we want to ask about diabetes and cholesterol levels. If they can go for 4 more bloods for that, that's great. If they consent to, and if the clinic has those finger prick tests, we can do that as well. And we can also counsel regarding other risk factors. When I talk about diet and lifestyle, the topic that I often like to discuss is salt use in food, because that is a big problem with regards to treating blood pressure. So the guidelines say to advise salt restriction of less than a teaspoon a day. That's very, very little salt. If anyone that cooks, you will know that it's not going to be great to season your food, your entire food, with less than a teaspoon a day, but that is the recommended guidelines. I think we've all just gotten very used to eating highly salty foods. So do counsel about that. If they cannot stop completely, at least they can cut back and restrict slowly like that. Then the usual regular exercise of 30 minutes a day for 5 days of the week is also a good lifestyle modification for them to add on. Advise weight reduction if they need it, to stop smoking if they are, to avoid NSAIDs and the combined oral contraceptive pills if they're on them. We can discuss about that, and the women who are on contraception, they can be switched over to a progesterone-only contraception as well. And then to also counsel them regarding some of the side effects that they may notice. So very often when patients do start blood pressure medication, they will tell you that they actually start feeling a little bit more ill than they did with the hypertension. And that is just the body's response to adjusting to the now lower temperature, the now lower pressures. Do advise them that it's normal, they will adjust, they will feel better in time, and that it's very, very important that they are adherent to the regimen that the doctor has prescribed because of all of the risk factors that high blood pressure puts them at risk for, like the strokes, the heart attacks, the dangerous things that can happen from having uncontrolled high blood pressure. Then you also want to counsel regarding regular blood pressure checks and then the danger signs. So what are the danger signs? It's usually visual disturbances, chest pain, dizziness, confusion, headaches, shortness of breath, or sudden hemiparesis, like paralysis, where they're saying one arm and one leg is not working very nicely. Or it can be speech slurring. So a family member will say that they're just not speaking clearly. You cannot decipher the words that they're saying. This is a hypertensive crisis when they present with any of these symptoms, and you would give stat 10 milligrams of amlodipine in the clinic setting itself, and then you would call the doctor. So do counsel them about these danger signs at home, that if they experience any of them, to please make their way to their nearest doctor or to make their way to the clinic, where you can give the stat amlodipine and get in contact with the clinic doctor. And then once they've been diagnosed, we want to follow them up monthly. I know this is not always possible, but if you can counsel that even if they don't follow up to see the doctor monthly, if they at least come into the clinic monthly to get those blood pressure readings checked, or if they can check at home or something like that. And then once we have established that they are well controlled or they know what to look out for, then we can see them 6 monthly and issue the scripts there. And then I always like to add on a yearly GFR screening just to make sure that their kidneys are doing okay. And I often ask about any visual disturbances, because if they are having any, or if they're known with vision problems, then they can perhaps also follow up yearly with regards to the eye problems that can result from high blood pressures. Then I just wanted to go through this renin-angiotensin-aldosterone system. So I'm sure it's in the back of all of our heads somewhere when we did physiology way back when. And basically, this is the system that controls blood pressure in the body. And why I want to go through this is because all of the drugs or the medication that we're going to be discussing here after, it all works on this same system. So basically, the RAS system, as we call it, is a series of reactions that's designed to help regulate the blood pressure. When your blood pressure falls for systolic to 100 milligrams or lower, then the kidneys will release this hormone called, or this enzyme called renin into the bloodstream. Renin then goes and splits this angiotensinogen into angiotensin 1, which is relatively inactive. And then that is split into pieces by the angiotensin converting enzyme, or ACE. So when we speak about ACE inhibitors, that step is important. So that converts angiotensin 1 into angiotensin 2, which is a very active hormone. And then angiotensin 2 is the one that causes the muscular walls of the small arteries, or the arterioles, to constrict, thereby increasing the blood pressure. It also triggers the release of another hormone, aldosterone, from the adrenal glands, which sit on top of the kidney over there. And that releases vasopressin, or antidiuretic hormone, from the pituitary as well. And then this aldosterone and vasopressin, they cause the kidneys to retain more salt. So if you remember from basic science, wherever there's salt, water will follow. Aldosterone also causes the kidneys to excrete more potassium. The increased sodium causes more water to be retained in the kidneys, thereby increasing your blood volume and your blood pressure. So that is basically how that system works. And then let's go through the drugs and we will chat about exactly how they work or where their function comes in. So according to the guidelines, the treatment of blood pressure always starts with thiazide diuretic. I often find, and I've also looked through some of the research papers as well, that a thiazide diuretic in itself is not really effective in lowering the blood pressures and often needs to be used in conjunction with other medication or treatment. So these are usually your Ridax or your hydrochlorothiazide. The patient will come in and talk about these water tablets. It's usually the little pink pills. You do get them round or you do get them in like those little octagon kind of shapes, but they can also be white. So don't be confused. Sometimes patients will come in and they will say, I'm on a blood pressure medication and I need a repeat script. And then you ask them what medication, they don't know, but they take white pills. It's very, very difficult for us to actually kind of ascertain what these white pills are because they could be any of the treatment modalities. So that often is a problem as well. This diuretic works in the distal convoluted tubule, and then it inhibits the sodium chloride transport over there. So more sodium is then excreted in the kidney with the accompanying fluid. So basically it flushes out all of that excess water that the RAS system was trying to gather to increase the blood pressure. You must please avoid the diuretic if patient is pregnant, if they have gout, or if they are known with liver or kidney disease because it can worsen it. Usually we prescribe it in 12.5 or 25 milligram doses. So you usually always start the patient on the lowest dose possible, and then you escalate from there until they are well controlled. And do advise the patient that they may frequently urinate once they start taking it. It's just their body passing out all of that excess water that they may have been retaining. And it usually does settle over time as well. Then the second line of treatment is the ACE inhibitor, so the angiotensin converting enzyme inhibitor. And these are usually your enalaprils. They stimulate the dilation of blood vessels by inhibiting the production of angiotensin 2. So it basically stops that conversion step of angiotensin 1 to angiotensin 2 in that renin-angiotensin-aldosterone system that we discussed earlier. It ranges in doses of between 5 to 20 milligrams. Sometimes it's given once daily, but usually, and the preferred prescription is BD doses, so 1 in the morning, 1 at evening. And with this, you need to also carefully monitor the patient's GFR and potassium yearly, and then also warn them that it can cause dry coughing or swelling angioedema as well. The dry cough is usually caused by the bradykinin. So once this angiotensin converting enzyme starts working, it also suppresses the reuptake of bradykinin in the system. So that is why the patients end up coughing. Then the third line of medication. So initially you're on a thiazide diuretic and you would put them on an ACE inhibitor. If they are having a problem on the ACE inhibitor, then your other treatment modality that you have is an angiotensin receptor blocker. It works the same as an ACE inhibitor, but it works on a slightly different pathway in that renin-angiotensin system. So it doesn't cause that dry cough or the angioedema. It usually has fewer side effects. It's not that it doesn't have any side effects at all. It's just usually better tolerated than an ACE inhibitor. So those are your other options that you can go with. Those are usually your losartans, your valsartans. They're usually in 50 or 100 milligram daily doses. And then we can switch the patients who are having problems on enalapril to these. You also sometimes get very nice newer combination pills where they've got some losartan or valsartan that's been combined with the diuretic already, so the patient doesn't have to take 2 tablets, or sometimes with costing it also even works out a little bit better. And how this one works is it blocks the vasoconstrictor and aldosterone secreting effects of angiotensin 2 by selectively blocking the binding of angiotensin 2 to its receptors. So instead of blocking the conversion, it's now just blocking the binding at the receptor to give you the same effect. Then the third line of treatment. So once the patient has been on a diuretic, and they've been on either an ACE inhibitor or an angiotensin receptor blocker, and they're still not well controlled, or if you need stat emergency control when they present in a hypertensive crisis, would be your calcium channel blockers. So those are your amlodipines, usually 5 to 10 milligram once daily dose. It's considered a peripheral arterial vasodilator. It exerts its actions directly on the vascular smooth muscle to lead to a reduction in the peripheral vascular resistance and thereby causing the decrease in blood pressure. So it works peripherally, and it can also cause the edema, the flushing, and the dizziness as well. The reason why we like to use this one in a crisis instead of your ACE inhibitors or your angiotensin receptor blockers is it doesn't usually cause that drastic drop in blood pressure. So when the patient presents to the clinic and we give them statin amlodipine, we're not really worried that they're going to pass out or go into a hypotensive kind of emergency immediately after. Then the other treatment modalities that we do have, these are usually done after the patient has been poorly controlled for a long time. All of the doses have been adjusted to the highest possible doses. Lifestyle and diet changes have occurred. By this stage, they would have probably seen a physician or a cardiologist, and then they may be started on furosemide. They probably have congestive cardiac failure if they're put on furosemide, and then they can also discuss using beta blockers as well, like your Carved or your Ols and those things. So those are your further treatment options, but they're usually specialist initiated. The other thing that came up in the guidelines was that once you've risk stratified in a hypertensive patient, it's wise to actually discuss with them simvastatin use prophylactically, especially in those with high cardiovascular risk, because lowering those cholesterol levels will further risk reduce them from having those CVAs, those myocardial infarcts, etc. Then it's also nice to chat with the patient about getting ECGs as well, just to check up on general heart health and to see that everything is good there, and referral to cardiology if needed, if they are very poorly controlled hypertensive, if we've tried everything, or if they're presenting with symptoms of target end organ damage or something like that. I hope that was a quick refresher, and I'm willing to take any questions if anyone has them at the moment.
Awesome. Thank you very much, Dr. Cassim. It was very informative and in-depth. So yeah, guys, if you have any question, you can quick look here. So if you press on your screen once, you should get, when you're on the iPad, you should get the options right at the top, or the top right section of the screen, where you can raise your hand, and there's a chat function as well. So clicking on chat, you can type. Let's see, there is one raised hand here. Let me just give you the option. So I can't see who it is, but yeah, just unmute yourself. Yes, go ahead. Hi, Sister. Yeah, we can hear you.
Hi, Doctor.
Hi.
How are you, Doctor?
I'm well, thanks, and you?
I'm good. Doctor, I've got a question to ask. There's a patient who is a known hypertension on treatment. Yes, is on Dopamax medication. He started with the treatment because the blood pressure was very, very high. But now my worry is this blood pressure is now starting to drop. It's dropping very, very badly. Like the BP, it will be sometimes 80/72. And then when he goes back to the treatment, then when he stopped the treatment, the BP rises again. And when he started the treatment, the BP, it drops. So how is that, Doctor?
So it's good that you actually brought it up, because sometimes patients are hypertensive for a long time. They're diagnosed maybe in their early 30s, 40s, and they carry on their treatment because they know they're hypertensive. They take these pills every day. But usually as they get older, so we see it a lot in the older population. How old is your patient?
The patient is now 58, and he started his treatment when he was 44.
So he's not that old. But usually as the patients do get older, we do see it, especially in the elderly, where their blood pressures kind of are lower than normal. And then they're taking these antihypertensive on top. So they end up presenting with severe hypotension. In that case, it's just basically a consult with the doctor to see what can they reduce the medication to. So can they lower the dose? Can they change the medication over to something that's a little bit milder, that's not giving them these hypotensive effects? And sometimes actually even in the severely elderly, we actually stop medication completely because their blood pressures are just dropping way too low. So it would just be seeing what doses he's on, dropping them from there, or altering his medication to something else so it's a little bit better tolerated.
Oh, okay, doctor. Thank you for that one.
I think there was a question that did come up, which I cannot see now, but I saw it halfway. In the chat. Yeah, it said, which level of high blood pressure may we not give injectable contraceptives? So the thing with contraceptives is, I know we always stress about blood pressure and we say, please check the BP. But when I look through all of the guidelines or everything that I could find, it's not actually contraindicated in a progesterone-only form of contraception. So the injectables, the neuroestorate and the other one, the depot, they're both progesterone-only injections. So I'm not really sure why they would be contraindicated. I think it would just be a little bit more cautious in someone with high blood pressure in giving those injections. But I don't think there's a true contraindication unless any of the other doctors have any insight as to why we would avoid an injectable contraceptive if their blood pressures are high.
Give it a second if anybody has input from the doctor side. In the meantime, again, if there are any questions, you're welcome to throw it our way. In the meantime, while you're having a thought on that, we did send you, guys, a mailer as well to just to remind you about the competition as well for this month, where we will have a prize giving as well as on the end of the month for the top used cases from your clinics. So that pertains to proper and the good information given regarding your consultation and in-depth clinical what do you call it, notes and that, plus then obviously the photos, should there be any, coming with your consultation itself. So you can just send us through that patient's name as well as the consultation number. And you can send that through to admin@udok.co.za, but there is a mail that was sent through to you. We'll follow up on that as well. If you can just send that before the 27th of this month, email through your own use case from within the clinic, we'll appreciate that, and then we'll do a prize giving at the end of the month. That's just a recap on that. Any other questions regarding this presentation?
Okay, so just to get back to answering the question that I read out just now, I actually did a quick search now on PubMed. And it turns out the progesterone in the depot and the neuroestorate are not contraindicated. So it's not contraindicated for the medication itself that you're injecting. The only reason why there's a contraindication is if the woman is hypertensive, she's already got a cardiac risk factor. And the contraceptive injections are another cardiac risk factor. So you're basically adding on and increasing her risk of a cardiovascular incident. That's the only reason the contraindication comes into place. So it's just basically identifying the risk factors and trying to risk reduce as much as possible, that you would advise her, let's try to stay away from an injectable, but ultimately the choice is hers to make, and it's not contraindicated for the ingredients of the depot or the neurosteroid itself.
Okay.
If that answers it a little bit better for you.
Sure it does. Any other questions, guys? You can, as mentioned, raise your hand by using the raise hand button, or otherwise the chat function if you wish to type. Give it another second. Just check something here. You're also welcome to ask any question regarding the platform or what we are about the prize giving of the consultations, the use cases. Should you have any? Okay, just see here. Screen share. See what it's going to do now. I'm going to do a screen share here from my side.
All right. Yeah, so thank you for refreshing our memory. I just want to check with you in terms of your, what is your, in terms of your practice, starting a patient on a new drug, what would your approach be in terms of follow-up? What are those follow-up timelines to recheck blood pressure value and go accordingly?
So usually if I start medication, I would tell them to come back within 3 days' time. So whenever they get a chance within 3 days' time, just to see that they're doing okay, they don't have any serious side effects, they know what the danger signs are to look out for. And then in 3 days' time, we can check the blood pressures again. But I'm not really so worried about the number that's produced in those 3 days' time to see that it's significantly low or anything. It's just more to see that they're tolerating it, that they're doing okay on the medication, and that their blood pressures haven't gone higher, in fact. And then I would follow them up within maybe 2 weeks to a month to actually assess that the figures have come down. But it's difficult because you can't really monitor on a single value or reading. So you have to ask them to come back maybe multiple times if they can check at home. So if they do have access to blood pressure monitors at home, that's always great. Or if they can check at a routine clinic and then just make notes of all of these readings so that we can kind of see where the trend is going. That would also be great, but it's kind of difficult. So you'd have to do it as a case-by-case scenario of how often they can follow up until we can get the blood pressures under control or within the desired range.
Yeah, no, that's good. And we see more and more people that owns their own monitoring device. Maybe so if you can just tell the nurse personnel out there, if there's a newly diagnosed patient and they can afford to buy their own blood pressure monitor, they're in the pharmacy, what would you suggest for them to tell the patient when to check and document those readings, how frequently, what time of the day, and to bring that data back or to consult from home and report that data back to the doctor?
So you'd want to take the blood pressure readings at home at around about the same time every day, just so that we know physiologically we're kind of judging it at the same gauge, because the body does run on a system. So maybe if it was early morning readings, so about 30 to 40 minutes after they've woken up, but they're still in a relaxed state, they haven't eaten or they haven't like excessively exercised or done anything strenuous, they can check their blood pressures there. And then try take it around about the same time every day. Or if they're doing it in the evening, try and make sure that they do relax for about 30 to 40 minutes before, so it's not just as they step into the door, or just after they've smoked or eaten a heavy meal or something like that.
Okay, thanks.
Okay, good stuff. It doesn't look like there's any more questions. I'm just going to do a quick screen share regarding the consultations of that. So Dr. Cassim, thank you very much for that presentation and for your time here. Much appreciated. You are welcome to sign off should you wish to, and enjoy the rest of your day. So from the sister side, just going to do a quick presentation on what you can or should be just have a look at regarding your use cases and your clinical presentation from the consultation side. Just get that all going. Okay, so you should all see my screen now. So I'm going to be there. I'm going to go to Udok. Go. So from within your consultation, when you do have a use case and a interesting consultation or request there, just make sure that you type in as much detail as possible pertaining to that specific case, so that you are that it's clear to the doctor what the diagnosis should be or what the consultation is about. And just a quick recap, obviously to take a photo should then be a need for it. So say for instance, this might be a skin rash or so, just make sure that the photo is clear. And again, in order to do so, underneath the section where you can type is the option take photo video file. You click on there, you use take photo, and you can obviously move your iPad around or the device. If it should be on the foot or so, you use the shutter button to take the photo, make sure it is clear, nicely in focus. And at the bottom, you have the two options. Left is retake, right is use photo. If you use the retake option, you can get it in focus again. If you keep your iPad steady and you press anywhere on the iPad or where it is that you would like the focus to be, you just click on the screen with your finger, take the photo. If it's nicely in focus and you're happy with that, you click the use photo on the bottom right. Once you've done that, you still need to upload it. So it has taken the picture, but you still need to click post message, and it will load that photo. So this is just to show you again. So what you see on your screen is exactly what the doctor sees. And just make sure that all your notes and everything you type there is complete. And then once you are done with that, you can make your notes or so, and then just keep track of it. So, and then whenever you are ready to send us your best use case before the 27th of each month, then you can just provide us. So what you'll see right in the top here, where it says timeline, this is consultation number 55. You will obviously have your number there. So take down the consultation number as well as the patient's name, and then you can send this through to us, and we evaluate that based on how clear and good that information is. So just to give you a quick recap on what that is. So we would be judging you, or that specific consultation. Just give me 1 second. Oh yeah, it has been. Just pull up the information again. Okay, so just record that, and it was sent through yesterday. So you can just provide us with that details. So it will be on how clear, so the judging factors for these consultations will be how well the data was presented to the doctor via the timeline. So this is what you will enter there. And the image quality, so as I mentioned. And then obviously once the consultation has been finalized by the doctor, let's do that quickly. So once that consultation has been completed, you will then receive the documents. So again, consultation is completed. Then please use this rating, the star rating section, where you rate that particular consultation with the doctor. This is actually from the patient side, so you can ask them how they felt that was, and put in the comment, so that we can actually improve our service. And praise is always welcome as well. So whatever you type there, not text, of course. And you will also then obviously have the options here, the buttons for prescription, if they, and all the documents that was issued, and send it right through from those buttons. But yeah, so once you're done with that, and obviously you log out of the patient, you can still go to consultations at the top left. Whichever patient you deem was a good case, you can go and click on preview and just recap and check that before you start, and we'll have a look at that. So yeah, that is the short and long of it. Yeah, should you have any other questions, feel free to send us a mail at clinicsupport@udok.co.za if you need any more information or if there's any questions. And yeah, thank you again for all of your time. And yeah, have a great week ahead. We will check in with you next week, Wednesday. So have a great week ahead, and then let's hope you have a nice and good sort of cases coming your way. And yeah, great stuff. Keep up the good work. We appreciate. All the best.